Thank you for attending. What we're going to talk about today is a novel way. It's a device that that is really in the wheelhouse of the urologist to be able to insert. And it is going to limit the toxicity we get from radiation therapy. And I think that when we're done with this conference or this talk, you got to ask yourself, why would I use it? It's why wouldn't I use it? And so what we're going to talk about is this prostate rectum spacer. What is SpaceOAR Hydrogel? And I'm going to show you the clinical trials as well as how to apply this. And we'll talk a little bit about reimbursement also. We know the incidence of prostate cancer, 161,000 cases this year, 26,000, almost 27,000 men died. Now we know radiation is a common treatment, whether you use 3D conformal, IMRT, SBRT, brachytherapy, or even proton. Probably the biggest complications we get are urinary, GI, and sexual. And so the organ at risk is the rectum, and it has been the dose-limiting factor. And when we get toxicity and complications, we get bleeding, frequency, urgency, pain, fistulas. These patients can be a real problem when they get these complications. You know, and I say, well, it doesn't happen very often, but it happens to you, it's 100%. But you really have this quality of life loss when you have a rectal injury. And you also can have urinary and sexual symptoms that can affect the patient's health and quality of life, not only in the acute situation, but for years afterwards. So when we have radiation, the anterior rectum is really exposed, and it's unavoidable to get some rectal radiation because it's in such close proximity to the prostate. And when we're doing the treatments, we get prostate movement during treatments and even in between. So it would be nice to have something that would separate that so that you can decrease that toxicity in the anterior rectum. And when we look at some of the GI toxicity, this is grade 2 toxicities in some large centers using hypofractionation. And that's where they're getting real high doses of radiation. The CyberKnife. And so when we look at these large centers, multi-center studies, that the grade 2 toxicity, grade 2 is where you actually have to give treatment. It can be analgesics, it can be parasympathetic, things like Lamodal, and patients may be wearing pads. And so that's the grade 2 toxicity. But you can see that those numbers range between 14 and 25% in patients, and they can be acute and even be these chronic toxicities. But the SpaceOAR Hydrogel is a novel agent that is intended to position the anterior rectal wall away from the prostate during the radiotherapy. And in creating this space, the intent of the SpaceOAR system is to reduce the radiation delivered to the anterior rectum. Now, it was cleared by the FDA in April of 2015. And what the SpaceOAR Hydrogel does is it temporarily positions the anterior rectal wall away from the prostate, and you get this space of about 1.3 centimeters. And this space can reduce the radiation dose delivered to the anterior rectum and thereby significantly decrease your toxicity and side effects. So you can see this hydrogel spacer spacing the prostate from the anterior rectal wall. And this is what it would look like on an MR. You get this big white area of this hydrogel. And it goes from a liquid, that's how we put it in, and then it turns into a solid probably within 10 seconds. And then over a period of time, it will liquefy, and usually by 3 months, it's liquefied and it gets absorbed into the system. And so the material is made mostly of water and polyethylene glycol, PEG, and it's used in numerous medical products, so it's not anything really new to us. We see it in artificial tears, prescription drugs, medical implants. It's synthetic, it's biocompatible, non-toxic, and it absorbs in approximately 6 months. And the procedure is an outpatient procedure. It can be done with local, regional, or general anesthesia. I think when we first started doing it, we were using MAC, but we're now doing it under local, so that patients usually take something like oxycodone, 5 to 10 milligrams with a Valium 5, and then we do our standard kind of block for the prostate when the patient gets there. And we've been able to do it with local in our ultrasound suite. So it's easy to give, and I think the more experience you get, you're going to get more comfortable with doing it that way. However, there are some patients that have got general anesthesia or even regional blocks. But it enables the dose escalation and hypofractionation because it offers this space of about 1 centimeter. And it does that for about 3 months, so that after they're done with treatment, this thing absorbs. And there was a 73% reduction in that rectal V70 dose, which is the dose that causes the problem. And there was 0 late GI toxicity of a grade greater than grade 1. Remember, I showed you in that other slide that we had a percentage of about 15 to 25% of these patients were getting grade 2 complications. And so the value is that it provides a treatment option for patients who have recurrence, maybe another chance for cure. It reduces the rectal dose and rectal complications, and we've got some validated quality of life measures that prove it in patients, and these have been validated. And it enables dose escalation so that you can deliver more radiation to be tumoricidal. And it allows for shorter treatment periods. So if you're going to do these hypofractionated cybernized in 5 days with high doses, it'll allow you to do those patients and move them through your clinic pretty well. So here's how we apply it. So when we do the application, it's injected through an 18-gauge needle. We have some liquid hydrogel precursors that we mix, and I'll show you that in another slide. It solidifies within 10 seconds. And it lasts about 3 months and totally absorbs by 6 months. And so it's a water-based polymer. It does not heat up during polymerization, and it breaks down via hydrolysis. And it flows through the perirectal fat, which kind of locks it into place, so it stays in that position. But this is how it looks. You can see that black line is actually that target area. We're getting into de non-VA's space, and it's in between the de non-VA's fascia in the posterior prostate and the perirectal fat in the anterior wall. And so this is a little pictorial here. So what we do is we first create, where you see that needle, that's the hydrogel that's going in. But what we do is create a little space with saline first right in that area to open it up. And then we keep the same needle in and then apply the hydrogel. I didn't get to see this whole thing on my computer. So, and you get this 1 centimeter space for about 3 months. And I think the more you do, the comfort level, it doesn't take that many to get a pretty good comfort level with this. Again, this is in, within our wheelhouse, and we have the ability to do that because we do these kinds of procedures. And so the clinical trial results, so they randomized 222 patients in a 2-to-1 fashion to get SpaceOAR or it was a sham, so that those patients didn't get anything other than the fiducial markers. I'm trying to see this a little better, but as far as prophylactic antibiotics, 95% of the patients got it. We use Levaquin. You can use anything that you want to do. Remember, we're not going transrectally. So it's really, low risk of causing any kind of contamination in there from the rectum. But this was all done transperineally, and the procedure was rated by the doc who did this as 99% easy or very easy. And there was a 99% technical success of getting this into the location. And we really didn't have any perirectal injuries there with this. So the summary of this trial was that we create this space in between the prostate and the rectum. There was 74% less rectal radiation applied and 75% less rectal toxicity, grades above 1+. And so when we look at the late toxicity, it was a grade 1, and it was 75% less in the SpaceOAR patients than before pre-spacer in the controls. And as far as late grade 2+ toxicities, there were none compared to 6% of the control arm. So that we had a 75% relative reduction in the grade 1 toxicity, 100% relative reduction in grade 2 toxicity, so that we had 0 grade 2 toxicities, and there was 73% relative reduction in cumulative grade 1 urinary incontinence. And when we look at the dosimetry, we had 73.5% less dose volume to the anterior rectum, and the penile bulb also had less exposure to radiation by about 48.8%. And they use penile bulb as a surrogate for getting the neurovascular bundles and also the continence mechanism at the urogenital diaphragm. So that's what they use for the kind of a surrogate marker. And the overall benefits, patients in the control arm had less, their quality of life issues were less for the bowel, urinary, and sexual dysfunction than the patients with SpaceOAR. And so it was pretty dramatic difference in the quality of life measurements. And so the control patients experienced a significantly higher amount of this MID, which really translates into worse complications when it came to the rectal, bowel, and urinary. So when we look at the reimbursement landscape, it's now being covered by many payers. We've got lots of data out there. It's been endorsed by a number of different societies, American College of Radiology, American Society of Radiation Oncology, ASTRO, as well as the NCCN. And more third-party payers are looking at this and paying. Palmetto approved it in October of 2017, and there have been over 15,000 SpaceOAR hydrogel procedures performed with about 10,000 in the United States. And it now has a category CPT code which began on January 1st, 2018, so we should be seeing some reimbursement. And these are the proposed reimbursements. If it's done in the office, it's almost $4,000 as an outpatient. We get a similar type of reimbursement. We get much less in the ASC, and then the physician component is pretty low, but you're actually making up for it if you're doing it in the office or as an outpatient. In your center, you're probably going to have about a $1,000 margin per case. So the value is that it reduces the rectal toxicity. You can use it in dose escalation, SBRT, and salvage options, and it's very easy to implement. So with that, I'll take some questions. There's actually going to be another publication here. It was published online in November of 2017, reviewing some of the different cases, but it's really from a urology perspective. We think that we have the skill set to do this, and there's no reason why we can't own this procedure. Radiation oncologists are doing it, but I think it's something that we have right in our offices, and it's something we should be incorporating. And if you're not doing it, you have to ask yourself, why not?